Did I get started? Or are we waiting for anybody else?
I think you're good to go.
Okay. All righty, let me just get set up here. All right, so I'm going to be speaking on sports nephrology and just hitting on a little bit of urology. I tried to focus this presentation on questions that I saw and board prep questions, as well as some of the study guides that I used to make this presentation. Okay, just to review the objectives, I'm just going to review some basic renal anatomy and physiology and just discuss some common renal and general urinary pathologies that we can find in our athletes. So just to review the anatomy, at rest, the kidney receives about 25% of the cardiac output, which is approximately 1 liter of blood per minute. It's one of the highest of all the organ systems in the body. So it's really important that we're able to kind of understand balance of renal perfusion. At rest, this renal flow is continuously filtered by the glomerulus. 99% of this is reabsorbed into the tubular system. ADH is a really important regulator of fluid shifts in our body. It helps reabsorb water by increasing the permeability at the distal tubule of the nephron and the collecting duct. Some of the main stimuli for ADH include increased osmolarity if you have a decreased volume due to potentially dehydration, decreased blood pressure. And ADH can actually increase threefold with heavy exercise to help prevent free water loss and dehydration due to sweat. Exercise actually results in decreased renal perfusion, and that is proportional to the intensity of the activity due to the shunting of blood from exercising from the renal area to the exercising muscle. And this is done via constriction of the afferent and efferent arterioles due to the increased circulating levels of epinephrine and norepinephrine. So with moderate exercise, you can see a 36% reduction in renal perfusion. It tends to increase as you increase your activity. So with a strenuous exercise, if you're about 50% of your VO2 max, you lose about 30% reduction. If you have maximal exercise, about 65% of your VO2 max, you can have up to a 75% reduction in renal blood flow. And this renal blood flow decreases further if the individual is at baseline dehydrated before starting activity. And then this blood flow typically returns to normal or to pre-exercise levels within an hour of cessation of the sport. So the first thing I'm going to talk about is hematuria. So this is detection of red blood cells in the urine, which can be an indirect marker of myoglobinuria or muscle cell breakdown we can see on dipstick. So this hematuria can be gross, which is the presence of red in the blood, or microscopic. Microscopic is defined as 2 to 3 RBCs per high-powered fields, and the urine depth is pretty sensitive at picking this up. They can pick up about 1 to 2 RBCs. And this is typically caused from vascular leak of blood into the urinary tract. Most often the lower part of the urinary tract. So we're talking about the bladder, the urethra, the prostate, but it also can be from renal origin, and that is, if that is the case, can be a little bit more concerning. But there is, generally we can see hematuria in the general public. Up to 5 to 6% of the general public has hematuria, and it can be asymptomatic, and then many times it is transient. And in our athletes, it can be as high as 75%, and it's fairly prominent in our ultra endurance athletes. And the etiology for benign hematuria, but the etiology of hematuria in general can be for a variety of reasons, which I'll discuss on the next slide. So I have a lot of the etiologies listed below. We'll just go one by one. So we can have non-traumatic hematuria, causes of hematuria, and this can be from decreased blood flow, which leads to ischemia in the nephron and increased permeability, which allows the passage of RBCs into the urine. Also, an increased glomerular filtration pressure secondary to vasoconstriction can lead to, again, this passage of RBCs. You can also have hematuria if you have a traumatic event. So this can be a direct trauma to the flank, a helmet to the flank, a ski pole, fall off a balance beam, versus an indirect trauma, which is, jarring, jumping, running activities, which just cause a little bit of mechanical injury to the urinary tract, to the renal tract. The bladder is also another etiology of hematuria, especially with sports hematuria. The bladder, it's almost always traumatic. It can result from a single blunt trauma or just multiple lesser forces. And if it is a repetitive trauma of a flaccid bladder against the anterior wall, known as bladder stop, which I'll discuss a little bit later in our talk. And blood can also come from the urethra or the prostate. This is usually traumatic. Again, a repetitive trauma, especially if a cyclist does a lot of hours on the bike. They can have just this jarring against the seat, and this also may be exacerbated by improper seating height and pitch. And then more medical reasons of trauma, of hematuria to kind of think about. So nephrolithiasis, if there's a UTI, the person does have, sickle cell anemia or trait. These populations have increased risk of renal papillary infarct, malignancy, especially in our older populations. Drugs are another component of potential hematuria. Meds like penicillin, thiazide, allopurinol, NSAIDs, something we take all many times daily, and even OCPs can cause hematuria. In our athletes, there's also this phenomenon discussed as heel strike hemolysis, where the constant banging of the foot against a hard surface leads to hemolysis in that area, and then the haptoglobin then binds to hemoglobin, and then when that haptoglobin becomes saturated, the hemoglobin is excreted in the urine. And then rhabdo, a very important other consideration given our athletes, which I'll discuss later as well. And then we can also have hematuria. This is red-colored urine without the presence of RBCs. Microscopy, and then this could be attributed to antibiotics such as Bactrim, macrobid, phenytoin, or even just foods such as berries, beets, and food coloring additives. And so how do we kind of assess what to do with the hematuria? So the diagnosis can be initially done on dip, but you need to confirm with a microscopy to rule out any kind of other etiology, or to get a better look at what the breakdown of the urine is. The timing of the hematuria during urination is also an important thing to consider. If it begins at the beginning of urination, it's usually in that lower tract, that urethral origin. And if it comes towards the end, it may indicate something higher up in the bladder or the prostate in men. But if it is continuous and it's happening throughout the stream, it's important to think about a renal etiology where the blood is coming from. If you do want to do a further workup, obtaining a CBC can be helpful, because looking at the MCV can determine whether or not it's glomerular or not, given the concern for renal pathology. You can also look at the RBC morphology at that point in time. And then you want to further look at the UA to look for any CAQ and dysmorphic appearances of the red cells, which also indicate glomerular origin. So treatment, obviously it depends on the cause of what you think it is, but if you do think it's transient benign hematuria, and that you've done a thorough history looking at the physical exam and diagnosis, you should repeat the UA. You should have the patient stop exercising for 24 to 72 hours and then repeat the UA that time. And the hematuria, if it is exercise induced, should resolve in that time. But in our endurance athletes, it cannot take up to 7 days sometimes. So maybe just having someone take off a week and then retesting the urine. If it does clear, you can essentially diagnose them with exercise-induced hematuria, which is a benign population. But if the person is a little bit older, or if there's any concerning symptoms or history, you should do a further workup or send them to get a further workup by their PMD. So the red flags essentially are risk factors or hematuria that is gross or persistent in a patient that's over 40 years old. It's important to check the blood pressure, because that would further indicate whether or not that may be coming from a renal etiology. Getting urine culture, just to rule out any kind of UTI. Also important to get some just maybe baseline labs, a BMP, to see what their BUN creatinine is. You want to see the electrolyte profile to see if anything is deranged. A CBC could also be helpful, because if there is anemia, there is again that concern that it could be coming from the kidney. And then in high-risk populations, maybe getting a sickle cell trace may be helpful, because then you could explain why they're having this intermittent bleeding in the urine. And if you do want to go a step further, you can get a renal ultrasound or CT to directly visualize the kidney. And then you should consider doing these things if you really do think it is an intrinsic renal disease. So the next thing I'm going to talk about is nephrolithiasis, one of our causes of hematuria. It's fairly common in the population. 15% of white males can have renal stones, and up to 60% of all women can present with stones. And this group, unfortunately, does have a 50% recurrence rate. The average age of the onset of renal stones is in the 40s for both men and women. Women have it a little bit earlier. The type of stones is most usually a calcium oxalate stone. We can also have calcium phosphate, uric acid, and struvite stones. And then people who have these stones may be at increased risk due to dietary or medication. Certain medications or dietary habits can increase your risk. So those who take corticosteroids on a regular basis, a lot of the vitamins C, D, and B can increase your risk of having stones. And then those who eat a high sodium diet, ingest a lot of animal protein, who have a low fluid intake, or even a excessive or low calcium diet can increase your risk of developing stones. So a study was done that showed that a balanced nutritional consumption of calcium demonstrated to be protective of the risk of stones by reducing that calcium oxalate availability and urinary excretion. But if they've found that if you take calcium supplementation in between these meals, you don't have as much benefit from that oxalate clearance. Again, increasing your risk for stone formation. So these patients can be asymptomatic if the stone is small enough. Essentially, symptoms develop when it typically passes from the renal pelvis into the ureter, and this pain waxes and wanes in severity. And the obstruction kind of determines where the location of pain is. So if it is in the upper part of the renal tract, you'll have flank pain, and then it kind of descends as it goes lower, with a lower obstruction. It may radiate to the testicle or labia, and so for that lower GU pain, and then this pain will again migrate as it kind of descends the tract if it's able to fit. And so you want to get a UA. On UA, these people will have the microscopic hematuria most usually, and they'll have the presence of calculi as well, which can be found after the fact if they pass the stone. So the gold standard in adults is actually getting a non-contrast CT. It has pretty good sensitivity and specificity. In kids, actually getting an ultrasound is first line. But then you can also defer to CT if ultrasound is unable to visualize the stone. So the management for these patients include, good hydration and analgesic. If the pain is really severe, they should be sent to the emergency room, because some people require narcotics to reduce the pain. And then the stone will eventually pass. Typically, if it's less than 5 millimeters, it will pass spontaneously. And then if it's greater than a centimeter, then typically they need some kind of surgical intervention to remove the stone. And then prevention, again, is maintaining good hydration. And then if you do have a past stone, getting an analysis of the stone can kind of further help management in terms of dietary habits that may need to be implemented to prevent this from reoccurring in the future. The next thing I'll talk about is rhabdomyolysis. It's characterized as muscular necrosis and release of intercellular contents from the muscle that leaks into circulation. As I learned with Matt last week, strenuous exercise depletes ATP in striated muscles, and this depletion can cause increased calcium into the intracellular area, causing dysfunction to the ATPase and calcium ATPase pumps. The high levels of intracellular calcium activate proteases and reactive oxygen species, essentially accumulating in the cell and causing necrosis and release of contents into the circulation. Athletes are already predisposed to renal toxicity given the increased levels of epinephrine and norepinephrine during exercise, as I described earlier, due to the vasoconstriction and decreased blood flow to the kidneys. In addition, relative dehydration and subsequent physiological decrease in renal perfusion can again further the body's ability to limit and diminish these muscle breakdown products. Risk and co-founding factors that increase your risk of rhabdo is, hypo or hyperthermia. If you do a repetitive activity, oftentimes there's an eccentric load that tends to increase the predominance. If you're overexerting yourself, especially those who are new to a particular type of volume of exercise or increased intensity or duration, if you are at baseline ill, if you have a bacterial or viral illness, this increases your risk. Again, certain drugs can increase your risk for rhabdo, including stimulants, benzos, SSRIs, antipsychotics, and even some recreational drugs such as alcohol, cocaine, and amphetamines. And then sickle cell trait is again increased risk of rhabdomyolysis, but with the caveat of increased risk of sudden death, which have been observed in a few studies in the past. So diagnosis of rhabdo, you have to have a history of strenuous exercise, and it's characterized by a triad. You have muscle pain, you have muscle weakness, and you do have detection of red to brown urine, which essentially is that myoglobin from that damaged muscle. So the way that we're able to kind of quantify that in the blood is looking at the CK, which is the creatine kinase level in the blood. And typically this level, when level is more than 100, it typically tends to be visible in the urine. So on urinalysis, they'll have heme, they'll have blood, but there will be no RBCs seen on microscopy. And then if you were to do a serum CK, you would see levels typically up to 5 to, there's no diagnostic cutoff for CK, but typically we diagnose rhabdo as having 5 times the upper limit of normal, whatever your range is per the lab. But this is not really very accurate in active populations because they do a lot of times have some baseline elevated CK. But what's typically accepted as rhabdo is anything over 1,500 to 100,000 units per liter. In terms of the way that CK rises, it peaks, between 12 and 96 hours after exercise. And with this elevation, you can also see derangement in AST because that's also found in skeletal muscle, as well as potassium because that's another intracellular content that could be visualized with the muscle damage. So management of rhabdo is just requiring aggressive hydration. Typically, you start with isotonic saline at a rate of 1 to 2 liters an hour. Bicarb can be added to IV fluids for people who have severe rhabdo, especially if the units are like in the thousands. You just want to alkalize the urine to kind of help decrease with cellular contents. So the goal of urine output for rhabdo is to have at least 200 mL an hour of urine with this rehydration. AKI or acute kidney injury is a common complication of rhabdo, and we're concerned about that because it can progress to renal failure. And AKI is reported to be as high as 15 to 50%, which is why admission for these patients with severe rhabdo is warranted. Lower risk patients or those who have levels less than 20% are less likely to have this AKI, but it's just very important to monitor electrolytes because they can have hyperkalemia, hyperphosphatemia, and low calcium. And just following the BUN and creatinine to assess the renal function. Like as I mentioned before, CK tends to rise within 12 hours of exercise, and typically is at its max within 72 hours. And a decline can be seen, but it's a slower decline. It can take up to 3 to 5 days to kind of get that creatinine cleared. And then some potential complications of rhabdo include compartment syndrome from the muscle that's injured from swelling. You can have metabolic acidosis, electrolyte instability, which can increase your propensity for cardiac arrhythmias. You can have the renal failure, as I mentioned, and it can also progress to DIC. And so once the patient is cleared, they've been discharged from the hospital, they need to be asymptomatic and they shouldn't be having any pain. And their labs have to be normalized. There's a recommendation just a gradual progression to intensity and volume of exercise that's submaximum over a course of 3 to 4 weeks. Next, I'll be talking about exercise proteinuria. At baseline, normal adults can secrete up to 150 milligrams of protein in the urine daily. It's typically composed of equal parts of albumin, serum globulins, and tissue pressure. And athletes, it can be increased. There's a phenomenon of exercise-induced proteinuria that occurs after exertion and is typically asymptomatic. This proteinuria typically resolves within 30 minutes of exercise and clears within 48 hours. The etiology of the exercise-associated proteinuria is due, again, to this increased angiotensin during exercise, which results in increased protein filtration through the glomerular membrane. Strenuous exercise also activates, again, the sympathetic nervous system, again, increasing your catecholamines of epinephrine and norepinephrine, and also increasing membrane permeability. Also a drop in pH, so increased lactate that's done with exercise also alters your glomerular permeability. So also, while you can have some baseline proteinuria, it should not be more than 1 to 2 grams a day of protein, because if it is more than that, it's more concerning of a renal etiology versus exercise induced. So again, this can be detected on urine dip or UA. The dip can detect up to 20 to 30 milligrams per deciliter of protein in the urine. And if your UA was positive for protein and was done within 24 hours of exercise, you should have the patient stop exercising and then repeat the UA into 24 to 72 hours to determine whether this is a transient proteinuria or if it's persistent. We can also have false positives on the UA for proteinuria. So if the urine is very concentrated, the patient's very dehydrated, there can be contamination with an antiseptic. Pyridium, which is common in azo, UTI prevention medications, can make a false positive. And then if the urine is highly alkalized, it can come up positive. So for these patients, again, a thorough history needs to be taken of their personal and family history of any kind of renal disease, if there's any associated anemia, hypertension, especially in the pediatric population. It's important to assess that this is not coming from a renal etiology. So if your blood pressure is high, get a manual reading, and then if it's a history of diabetes or, again, medication use can increase proteinuria. So the workup, I guess, very similar to the hematuria. You want to get BMP to look at BUN and creatinine. If you want to take the workup further, you can do a 24-hour urine to look at the total protein creatinine and the creatinine clearance. Might be a good idea to get a CBC just to check for the anemia, as mentioned before, to make sure it's not coming from a renal etiology. An A1C might be helpful if there's a history of diabetes. It could be having some injury from that. And if you do want to, look at the imaging, renal ultrasound or CT would be warranted at that time if you had concerns. So treatment for exercise-induced proteinuria, there is none. If you do have that second UA that is negative within the session of exercise, there's not much to do, and it's okay for them to return to play right away once you get that confirmation. But if the proteinuria persists, further workup is warranted and needed before you can clear them for sport. So athletes with a solitary kidney, it's actually not as uncommon as you would think. The incidence of unilateral renal agenesis is 1 in 500 to 1 in 1,800. So many athletes actually probably have a single kidney without even knowing it, and many times it's found incidentally. Also, we need to think about patients who have had a nephrectomy, whether they had some kind of oncologic history that required a kidney to be removed. So though contact sports have shown a very low rate of kidney loss, it's very important that you discuss the risks with the athletes and their guardians. Participation in athletics should be, a group conversation with the family and yourself and providers to consider the age of the athlete, the type of sport that they're doing, the motivation for participation, whether or not they want to participate in something that might potentially increase the risk of losing an organ. And then it's also important to kind of recognize the functionality of the kidney that's left. So the position, the size, and how much it is good at regulating what it's supposed to do. So most physicians agree that athletes should be excluded from contact and collision sports, especially if the remaining kidney is ectopic, multicystic, or any kind of degree of obstruction, which could impair its function, because essentially that's the only thing that they have left between them and dialysis. So you want to be very, very sure that that the kidney that they do have is well regulated and is working. So again, high risk sports should be avoided as much as possible. So this is bicycling, dirt biking, anything where you can have a fall. And then things that are moderate risk, like skiing, snowboarding, should be taken under serious consideration. There's been talk about protective equipment, wearing a padding or some kind of jacket to kind of decrease the blow, but no empiric evidence has been helpful or supportive thus far to determine whether or not that it actually matters or has been helpful in reducing kidney injury. Next, I'll talk about renal trauma. Typically in sports, the trauma is caused from blunt or a blunt trauma, but there you can also have injury to the kidney from deceleration or a fall injury, or obviously penetration. But blunt trauma takes up about 90% of all common sports related renal trauma. And it's more likely to happen in kids than adults. It's estimated that 30% of renal trauma is from sports-related injury. And these patients may present with flank pain. They'll have CVA tenderness. Maybe they might have some ecchymosis or hematuria present on exam. The degree of hematuria that you see is not necessarily indicative of how traumatized the kidney is, and may not even present up to 50% of renal injuries. So if you do suspect that a patient has renal trauma, it's really important to monitor their vitals, especially if you have a true concern that it's there. So looking at their blood pressure for hypertension or tachycardia, which may indicate that they may have some kind of laceration to the kidney, which obviously would require emergent referral to the ER. And imaging those with renal trauma can be really, really challenging, especially from the sidelines, and you have a lot of other things going on. But in the adult population, and the adult population, those who have any kind of microscopic or hematuria, gross hematuria, any kind of microscopic hematuria with a change in the vital signs, or if you note that there's a significant mechanism of injury, they should be referred to the ER for further workup. And then similar in kids, the presence of hematuria, hypotension, and then again, a severe mechanism, they should be evaluated for imaging. And imaging and depends on how much time you have, how significant the injury is. The ultrasound can detect any kind of lacerations, but doesn't really look at the depth or extent of the true injury of what's going on. But it can be helpful in kind of determining any patients that need any kind of more aggressive radiologic investigation. So a past exam could be helpful on the sidelines, especially if you see dark collection of fluid in the retroperitoneum. It's pretty sensitive, and that would again increase the patient's risk of just one less step that the patient has to go through while in the hospital to get further imaging. But the CT of abdomen with contrast is the gold standard and essentially required for a definitive diagnosis for any kind of renal imagery. And the examining physician should also look for any kind of other warning signs or red flags, which I'll discuss further in the other slides. So there's a couple classes of renal injury. Grade 1 is just a contusion to the capsule without any kind of laceration. This is the majority of sports injuries. This may or may not present with hematuria, but flank pain is usually present. Grade 2 is a non-expanding hematoma. It's contained to the retroperitoneum, and there may be a laceration that's that is a smaller, less than a centimeter deep. And then 3 to 5 is a significant kind of trauma or injury, and a significant more injury that usually requires surgical intervention. So grade 3 is a laceration of the kidney that's greater than a centimeter without any kind of excavation of the urine or without any rupture of the collecting systems. Grade 4, again, further injury where you have injury to the main artery with a hemorrhage. And then grade 5, you have essentially shattering of the kidney. And these patients are really usually unstable, have hypovolemic shock, and this is very unlikely in sports. So return to play after renal injury for a grade 1 or grade 2, typically management is supportive care. they need to rest, and the hematuria has to resolve before they can return to play. And they typically recommend no contact for up to 6 weeks. If the patient did have a grade 3 to grade 5, they need a surgical consult and potentially a surgical intervention. Once they are discharged from the hospital, they can take up to 6 to 12 months to get back into sport, especially contact. So essentially, we're watching for the resolution of renal hematuria, and may take longer based on what your conversations with the athlete, the surgeon, and the family. So bladder trauma, it's a rare injury that we can see in sports. It's typically related to a blunt trauma on a distended bladder. So with a lot of activity, you can have repetitive contact of a flaccid bladder against the anterior wall, which again is this bladder slap. It can occur in athletes, especially those who participate in increased physical activity or long distance runs, tracks, swimming, lacrosse. They typically have suprapubic tenderness and they may present with hematuria. The rupture is rare in this population. And one way to prevent this bladder flap that we see in athletes is to have a partially full bladder, which helps protect that swinging of the bladder against the trigone. And then we're going to do some urologic pathologies in sports. So genital trauma, there's over 14,000 sports-related genital injuries a year. Most commonly, it's in the male. It's male predominant due to the anatomic differences and the prominence of their external genitalia. Bicycling actually has the most common sport associated with GU injuries. So we're going to talk about scrotal trauma. We care about this because it can lead to subinfertility and atrophic testes. The trauma can be crushed, which is essentially the testes just pressing up against the pubic arch from an impacting object, or it can be blunt trauma to the scrotum. 75% of testicular injuries occur from blunt trauma, and it's not usually bilateral, only about 1% of the time it's on both sides. But this direct trauma to the scrotum can cause a testicular contusion. You can have a hematoma that develops, or you can even have rupture of the testes. These patients will present with pain, pallor, nausea, anxiety. And if the pain persists more than an hour and it is acute onset from an injury, it's more important to kind of look at other etiologies or more severe injury, especially something like testicular torsion or rupture. So if it's just a basic scrotal hematoma or a testicular contusion, ice and elevation should be used to help with swelling. You can also give provide NSAIDs for pain, and then they can return to play once the symptoms resolve. And it's not a bad idea to get us a protective cup to try and protect this from happening in the future. And then if there is concern, if you do have an exam and there is concern for more severe trauma, you want to look and we should do a more thorough exam, especially looking at other, more significant injuries. So looking for blood at the meatus or ecchymosis of the penis or perineum, which may suspect a urethral injury and requires, emergent evaluation for surgical evaluation because they're concerned of rupture. The next thing I want to talk about is female injuries. Many times, female GU injuries. This many times occurs with straddling trauma. The vulva is a highly vascular organ, and trauma can result in a hematoma formation. If it is big enough, and large enough, it can obstruct flow, which would require essentially evaluation to help relieve that obstruction. There's also this phenomena called water skiing. Fall while water skiing can also increase trauma to the vaginal area due to water essentially coming up into the vaginal area. This is rare, but it can lead to vaginal laceration and bleeding. So there's something to be aware of in our water sports. The next is testicular torsion. It's probably one of the most important, serious, and potential serious acute processes affecting the scrotal content, because it may result in the loss of the testicle. So typically the normal anatomy is the testicle lies vertically and it lies anterior to the tunica vaginalis. Torsion, many times, these patients have a propensity to have inadequate fixation of the testes to the tunica vaginalis, and they may torse on the spermatic cord, leading to subsequent venous compression, edema, and ischemia to the testes, making this, a very serious emergency. Typically, the testicular torsion abnormality is called a bell clapper deformity. Essentially, the testicle lacks that normal attachment to the vaginalis, and so it rests, as you can see in the picture, like transverse within the scrotum. And many times, this abnormality can be seen bilateral, which predisposes these patients to testicular torsion. Torsion typically peaks in the pubertal age. About 65% is between the ages of 12 and 18, but it can technically occur at any time in a lifetime. On physical exam, these patients have very severe abdominal pain, severe pain in the testes. They may present with nausea and vomiting. On physical exam, they may have a high reading, very tender testes, and you may see that it actually is transversely oriented. There may be some edema or hydrocele, and then the most important thing to assess for is a loss of a premasteric reflex. So a lot of times they'd say that half of this patient population will, before true torsion, will have similar, essentially like reversible torsions, and interpain that essentially relieves itself. But this is different than an actual torsion where they're having significant pain acutely. Many times it can be due to trauma, the testicular torsion, but most commonly it happens spontaneously, kind of out of the blue. And so torsion is made clinically, and requires a prompt evaluation with the urologist. It can be diagnosed with color Doppler, but only if you are very unsure. It should not, getting imaging should not delay treatment if you do truly think that it's a testicular torsion. And so treatment, they typically, you can try a manual reduction. It may alleviate the torsion. You do this by laterally rotating the testes or to try and detorse. This may alleviate symptoms, but they still require urgent evaluation from the surgeon. And then the treatment for this is a surgical exploration and fixation orchiopexy, typically done on the contralateral side as well, just to kind of prevent this from happening in the future. So diagnosis of the testicular torsion you can do with color Doppler. Again, only do this if you are truly unsure if it is torsion. It's so emergent because it's irreversible. Injury to the testes can occur as soon as 4 hours after the onset of pain. And if more than 12 hours goes with the torsion, they essentially have to remove the gonad surgically. And as I mentioned, prophylactic orchopexy can be done to the contralateral side. And so on the left side of the screen, you can see the whirlpool sign. This is the spermatic cord essentially twisting on itself on ultrasound, and on the right you can see the color Doppler or the lack of flow on the left side there. All right, and then next I'll talk about stress incontinence. Essentially, it's voluntary loss of urine with physical exertion. Just to review some of the physiology of urination, the internal sphincter is a smooth muscle under involuntary control, which prevents a leakage under contraction of the bladder under sympathetic stimulation. And the external sphincter is composed of skeletal muscle under voluntary control, which prevents the leakage via contraction of the somatic nervous system. And so those with stress incontinence may have increased urination frequency, urgency, leakage with staining, post-void dribbling, and straining to complete the void. A lot of times they do have nighttime voiding and they can present with dysuria. Women are twice as likely to have stress incontinence as men. And then, up to half of regular exercising women report some degree of incontinence. Again, it's important to screen for incontinence because this may be a barrier to some women. to exercise, for people to exercise, especially in, we typically think of this as a postmenopausal issue, but it can occur in premenopausal women. Again, this path of this is, the pathology of this is thought to be due to inadequate sphincter function or pelvic laxity. And so it is precipitated by increased intra-abdominal pressure. Typically, it's a clinical diagnosis and doesn't require any further testing, but it's important to rule out any kind of UTI as the cause of their urinary symptoms. Recommendations for stress incontinence include Kegel exercises or pelvic floor exercises, so PT if necessary. Use of pads. Smoking cessation can also help with this. They've been studies decreasing caffeine or alcohol consumption. And then if, all else fails, behavioral modification like bladder training, timing voids, and managing constipation can help with this. Pharmacologic medications are typically not recommended because they have limited efficacy and they have increased side effects. So for people who are postmenopausal, you can consider doing a topical estrogen. Alpha adrenergics can be considered helpful to control the internal sphincter. And then if all else fails, surgical intervention can be done. And the last thing I'm going to talk about today is pudendal neuropathy. So pudendal nerves originate from the S2, S4 branch, and they come from the sacral plexus and innervate the external genitalia. They provide the motor component to the bladder and rectal sphincter in both men and women. So the pudendal neuropathy is increased with prolonged perineal compression, especially those who do biking activities. And there are certain points within the pelvis that it can increase your risk of compression. So the nerve can get stuck between ligaments in the sacrum that stretch when you do pedaling activities. There also can be increased friction at Alcock's canal, which is essentially the pudendal canal, from just saddle pressure alone. And this may cause direct nerve compression or may just impede arterial flow, causing these symptoms. Etiology, lifetime prevalence among athletes can be up to 90%, and incidence increases with age, increased body weight, and increased cycling time. So those who cycle more than 10 years and more than 3 hours a week have an increased risk of pudendal neuropathy. They typically present with genital numbness and tingling. It may involve the distal part of the penis and labia and make sense upwards to the scrotum perineal area, depending on the level of compression. And then they can have difficulty with defecation or reduced sensation with defecation. So one of the warning signs. And so the treatment of this is to essentially stop riding or to stop the activity until the numbness completely resolves. Ensure that you have a good level of the seat and that it is and the seat fits properly. And then upon riding, rising, when you do return to riding, rising from the saddle intermittently may decrease the recurrence of symptoms. There have been studies that look at like a saddle cutout to determine whether or not this has been helpful, but that has not been found to be helpful. So, and this is where you can find the sacrospinous ligament and the sacrotuberous ligament and the pudendal canal, potential points of compression. Those are my references. Thank you for listening.
Good job, Courtney. That was great.
Thank you.
Courtney, this is McFarland. That was awesome. I heard Mandy's still on. I have a question, maybe even for like the attendings that are on the call. The torsion portion was very useful. I'm wondering, I just can't imagine trying to detour somebody myself. Maybe maybe that's more common. So I'm wondering what the indications would be. If you had a suspicion, would you guys do everything you could to just like quickly, you need to get to the ER, potentially OR as fast as possible? Or is this something that like, if you're suspicion, you're going to try to manually detours? That sounds like it's one thing to like read it in the textbook. It's another thing to like be in a high school training room trying to detour somebody. It sounds pretty wild.
No, I think in our high school training rooms, I mean, none of our high school training rooms are more than 15 minutes from an emergency department, really, right?
Right.
So
right.
like, our current situation, I would not try to manually detourse. If you were,
Yeah,
you know, helicopter skiing with someone in the middle of freaking nowhere and
yeah,
you're more than 4 hours away from your nearest emergency department, then
cool.
there's no
Okay,
harm in
cool.
trying, right? Like you might as well give
Yeah,
it a go.
that's what I
And
thought. Okay, cool.
and you can sort of, you know, some people, they can try holding the testicle up themselves during transport to relieve some of the pain. But
Yeah,
you know,
yeah,
you have 4 hours, get them to an emergency department as quickly as possible is my answer.
yeah, cool. Okay, perfect. Thank you. Yeah, Court, that was great. Thank you.
Thank you for listening. Have a good Friday.
Thank you.
Great job, Courtney. Thank you.